So welcome to those who've joined our journal club before and those who are new. This is our third one of our question-based journal club, where we try and take a clinical question that's come out of someone's practice that leads them to search for some evidence and find some evidence, and look at that evidence together to see whether it might inform our practice. You've got Susan, Defna and myself on the team who try and arrange this, and this week we've got Noella Pereira, who has come up with the question and the evidence that she'd like us to review. And I'm hoping that Noella will be able to present that part when it comes to it. So that's just queuing you up. All right, so I always include an outline of what we're doing because we might get different people from week to week. So I'm going to introduce the concept first of what we're doing, a very brief overview of some of the principles and the process that we use for evidence-based medicine. And then Noella, I hope, will introduce a clinical scenario, a focused question, and then a search that has led to a piece of evidence. We'll then split out to do some individual work or group work if you're in groups, which is looking at the evidence. And this week, actually, we'll only really focus on the validity, and we'll look at the results together. And then we'll bring it back together to discuss those things and consider how we can apply those results. And then we'll wrap up, ask for some feedback and signpost some useful resources. Disclaimer, as always, whatever you come out of this believing based on the single piece of evidence that we assess, obviously that's only a single piece of evidence, and don't override clinical guidelines on the basis of something like this alone. So the proposal for what we do is that this is an interactive journal club. It's not death by PowerPoint. It's not one person presenting their view. We have a question, a search, and a single piece of evidence. We're going to appraise it as a group. We'll try to get an idea of what your views are before and after you review the evidence. And the aim here is that we get questions that are clinically relevant, that everyone gets to join in the work of appraising and gets to flex their EBM muscles, and hopefully gives you and us more opportunity to identify our learning needs and maybe for us to provide some teaching and resources. And we get to see if the evidence changes our views. The principles of evidence-based medicine actually are about more than just evidence. The evidence is only one part. So it's never just about reading a paper and saying, oh, the paper's good, that's what it says, that's what we do. No, it's about having clear questions, finding the best evidence that we can, and appraising that and applying it in the context using our expertise, using the patient's preferences and values where it's being applied to an individual patient, and thinking about whether it's applicable, particularly for interventions. Are the interventions applicable? Can we use them in our environment? So there's a lot of questions to ask, really, and it requires a lot of judgment. It's more than just a numbers game. Although sometimes the numbers get us excited. So the process that we tend to go through is to have a clinical scenario that leads us to a position of uncertainty, that we then try and distill a focused question, which we use to search and then pick out the best evidence and then appraise that. An appraisal is typically split into three sections, where first of all we look at whether the evidence is able to validly answer that focused question in its own setting. And then we look at the results of that study, and then we consider whether we can apply those results, if they are valid, to our population. And that may lead us to then make a decision. Now, if the evidence is weak, that may be still a sort of consensus-based expert decision. But if the evidence is good enough, it may mean that we get a really evidence-guided decision. And then if we're acting upon the evidence, we can then evaluate what the impact of that is on the individual patient or on lots of patients. Obviously, impact upon one patient, very difficult to assess. That first part is for the nominated team, and then the appraisal is for us as a group. So we get to learn by example and to learn by doing. What's a focused question? The idea is that we structure it around the patient or the population that we're interested in, the intervention, if it's something we're going to do to them, or the exposure, if it's about something that we think may cause a problem, and then what we're comparing that to, and then what are the actual outcomes we're interested in. We can't just say, is X better than Y? Because we've got to know what are we defining as better. what are the outcomes that matter to us, to our patients. We can use focused questions to be about treatments that we would give, about tests that we would use, about prognosis, about risk factors, etc. So we're going to have an example today of looking at risk factors. And this PICO framework is just a tool to help us make our question clear, so we can try and determine how well evidence speaks to our question. So it's not a straitjacket. A hierarchy of evidence will come up today. Different types of study, different study designs can be suitable for different types of question, but there are certain types of studies that we tend to prefer because in principle they're less prone to bias. And you'll have often seen, I suspect, these pyramids showing what's at the top of the tree and what's at the bottom. But it's important not to turn your brain off. The quality of the individual study matters. So for a question about an intervention, of course we would prefer a randomized control trial, but if the only randomized control trial is small and very poorly executed, but you have a very well executed observational study, that might actually be the best evidence. All right, Noella, I wonder, are you prepared to take us through the scenario and the search? I'll advance your slides as you need.
Yes, I'm here. Thank you, Andrew. So the clinical scenario here is you are a pediatric register at King's College Hospital, and we have a 6-year-old child, a female child, presenting to A&E with signs and symptoms of a lower respiratory tract infection, and she is currently febrile. And the SHO asks you as a registrar whether she should give ibuprofen, or she should avoid ibuprofen rather. And that's the question because of the recent evidence, whether ibuprofen should be avoided in this case or not. So if we could go on to the next slide. So that's the clinical scenario, because in children less than 18 years of age with a lower respiratory tract infection, would you use ibuprofen? And recent evidence has shown that ibuprofen could cause an effusion or an empyema in a case of a lower respiratory tract infection. And that's the reason we are afraid of using it, because of the complications associated with ibuprofen. So that was a question that came up to my mind, because we use ibuprofen so commonly, and this adverse effect is something that we should bring to light. So coming to the PIC or the PICO question, the population is those less than 18 years old. With
no, I think your connection's back.
Respiratory tract infection, and whether we should use ibuprofen as an antipyretic compared with not using ibuprofen, and the outcome here would be the complications of child or the next slide, please. Could we go on to the next slide? Sorry. So we gathered a lot of evidence on this to find out whether ibuprofen was effective or not, and we searched on PubMed. We found about 115 studies that that kind of gave us an answer to our question as whether ibuprofen was safe in children with a lower respiratory tract infection compared to any other antipyretic. We also looked on TRIP, and we found on the TRIP database just 6 studies after looking for pneumonia, lower respiratory tract infection, and the use of ibuprofen or non-steroidal anti-inflammatory drugs and their complications in such patients. And when we did a search on Ovid, we found 56 studies that matched our question, and we put all of them together, but eventually we zeroed down to a few studies that would clearly answer the questions, because many of these studies just gave us safety data on ibuprofen and its use in lower respiratory tract infection, but it didn't really answer our question as what were the complications associated with ibuprofen. So going through the pyramid, we decided to study those that were obviously more informative and kind of answered our question as compared to those who didn't. So at the bottom, we have the editorials, expert opinion, coming up mechanistic studies, and then case reports, case studies, coming up cross-sectional studies and surveys, and case control studies that give us a more clear picture, cohort studies, randomized control studies, and right at the top, systematic reviews and meta-analysis of those randomized control trials. So we picked on 3 studies that we thought were pretty good in answering this question. So to the left, we have the prevalence and risk factors of suppurative complications in children with pneumonia by Francois, which is a French study. And it looked at children between 28 days and 15 years of age with community-acquired pneumonia. This was a retrospective study. And they found that the use of ibuprofen did cause complications such as a pleural empyema and a pleural effusion in these children with pneumonia. But there again, it was a retrospective study. It wasn't a prospective study. And to the right, we have on the lower bottom, we have a study by Leroy, which again was a French study. This one was a prospective study. And it found that the frequency of hospitalization for severe bacterial infections after exposure to non-steroidal anti-inflammatory drugs was elevated. It was 0.6% as compared to the total proportion, the total number of admissions. So the attribution to non-steroidal anti-inflammatory drugs was 0.6%. There's a 0.6% chance of increase in admission because of severe bacterial infection. But the one that we have boxed, the red box, was the one that was the best of all the studies because it was a matched case control study, and the level of evidence is obviously far more in that pyramid of a case control study. So that's the study that we chose by Bourgeois, again, a French study that compared the use of ibuprofen and antibiotics, at least a 6-day course of antibiotics and ibuprofen within 72 hours of onset of an acute viral infection. And the odds of getting an empyema or a complicated pneumonia was
I'll pause you at that point because we'll get all of the delegates to have a look through this paper themselves, and we'll look through the results. So we'll not reveal the results just yet.
Oh, sorry. So
that
right. Was the best. Yeah, that was the best study that we chose because that was a matched case control study, which was higher up in that pyramid as compared to the other studies. But so we will review that paper in depth in the course of this journal club session. And,
great, thank you very much, Noella.
You're welcome.
Sorry, did you want to say something else?
No, over to you, Andrew, to take over, and we'll continue our session.
All right, thanks, Noella, that's great. So, first question, this is for you to chat in the box if you would. I'd just be interested in your views at the moment. Are you already, what's your views at the moment on giving ibuprofen to children with lower respiratory tract infections? And we're talking about well children who you're sending home. Do you have any, do you caution parents already? Do you advise against ibuprofen, or are you pretty happy with giving ibuprofen? Give us your views. So you could just say yes, in favour of ibuprofen, or you could say no, advise against ibuprofen, or you could say something else. So let's just see if we can get a few views. Okay, it's really interesting. I have a feeling if we were doing this journal club in France, we would get different answers. Okay, got a question about asthmatic. Has anyone ever seen a child asthmatic react to ibuprofen? I still haven't. French people very nervous. Becky, are you saying that the French people you know are nervous, or this is just generally French people very nervous? Right, great. Super. So overall, we've got basically people feeling pretty relaxed. So let's see if we'll worry you. Yeah, the anxiety is greater during the COVID pandemic. Is it rational? I don't know. Okay, great. Thank you for your views. That's really helpful. So your mission, we're going to share, let me just copy, actually, sorry, Susie, do you want to take over now? Because then I can copy all the text across.
Sure. So your mission is going to be working through the paper. So we'll send a link if you don't already have it. So open up the paper and the CAS checklist. And we want everyone just to work through the validity. So that's the first questions, number 1 to 7. So read the abstract, the methods, and I think we've blacked out an area, or we've highlighted in yellow the area to read, and the demographic table. Don't read the introduction, don't read the discussion, and don't read the results yet. And yeah, get started. We've got some slides with some terminology that we'll just cycle through, but if you have any questions, then just type into the boxes. But we want everyone to work at the validity. So the first questions, if you just work through it on the CAFS tool, you can type in directly.
That's just a reminder we've got together of what we mean by the different sections. So when we think about validity, we're really just thinking, are there any other things that are likely to bias the results of the study? We'll give you about 20 minutes, and it will take probably about 10 minutes at least to read, and then we'll talk through as a group. You can ignore the section on microbiology and the methods. You should all have seen the links in the chat to the highlighted version of the paper and the appraisal framework, or you can just download the standard version. I'll switch us over to the rotating terminology slides. That has a little reminder here of the question that we're asking, and then some of the other terminology to come. So please send us messages. Please send us messages if you have any trouble, any questions that arise. We would love to try and help. And otherwise, we will draw it back together in 20 minutes.
We've got 5 minutes left and then we're going to start discussing. All right, everybody, our 20 minutes is now up. So the next stage is to talk more about the critical appraisal of this paper. and see if we can tease apart some of the things that have come up. So I'd like to refer back to the CASP checklist, which you've all been using, hopefully, to be able to appraise the study. So let's start from the very first question. What we did, which worked previously, has been to type what you think on the chat, or you can just unmute and talk if you like as well.
It would be lovely to hear some voices other than our own.
Absolutely, that would be great. So the first question is, let's bring it up. Did the study address a clearly focused issue? So if I can get some of your responses. Okay, I'm getting some now. It seems to address 3 issues. Yes, that's right. Excellent. Okay, so let's tease some of these apart. One of the things that's come up is seems to address 3 issues. So in the context of what we were thinking about when we asked our question, when Noella presented, was specifically to look at ibuprofen or NSAID use and its association with empyemas. So as Shola said, they do talk about NSAID and empyema risk. Yeah, so there's multiple different ones, but NSAID and empyema risk is what we were looking at. So I just wanted to, so a lot of yeses, 1 no's. First of all, can BG8 Gen Peds say why that you think is not a clearly addressed issue? And at the same time, Christine, can you tell us why you don't think it's the best way? Because that's going to lead us to the next question.
The amount of fever that a patient has is a confounder. So maybe the patients who are having the empyemas are having more ibuprofen because they have more fever that's not responding to paracetamol, for example.
Yeah.
It may not be actually identifying what they are trying to look at in this study. Maybe a prospective study would be more effective.
Completely agree. And that brings us on to the next question. Other than a prospective, so you said prospective, did you mean like a cohort study, or what other studies can this question be answered with? Can we have some answers from the group, see what other people think? Yep, the outcome is rare. Theoretically, would there be anything else that we could use? Yes. Yep.
And Christine, I was interested, you suggested a prospective observational study could help, but I'm interested, do you think that would help reduce the confounding by indication, the fact that those with more fevers are more likely to get ibuprofen?
Yep, absolutely. So I think given that this is a treatment, you could technically do a randomized control trial to see the effects of it in one group compared to another. But as Harris mentions, it would be useful to get some of the observational data, and a case control study is an option to be able to do this, although we have to think about its shortcomings at the same time. So we say that it is a possible option to be able to answer this question. So now comes the more interesting bits about the cases and the controls. So the next question we have are, were the cases recruited in an acceptable way? Do we think, first of all, yes or no? And then we'll talk more about it in detail. And what is the case definition actually for this study? Okay, I'm getting some silence, so I'm going to put it out there, and I think that actually the cases were recruited in a way that was acceptable because they have defined a case. Oh, I've got Shola, excellent. Yes, so in terms of what the case definition is, these are children aged 3 months to 15 years with an acute viral infection in preceding 15 days, which Shola also says is an all right time period for follow-up. So the cases are those who have had acute viral infections between the ages of 3 months and 15 years. Perfect. So we have said that the definition of a viral infection is vague and possibly subjective. That's true because they don't define the symptomology of the viral infection at all. So that's a very good point.
But as a case definition, that's probably more about the controls, actually.
In terms of comparison between the two, yeah, absolutely. They're also yes, they give the names of what types of viral, Maggie, sorry, they do give what the viral infections may be, upper respiratory tract, lower respiratory tract, bronchitis, etc. They define that bit, but they don't give the symptoms, but we'll talk about that in a short while. The other thing that we thought that was good was that they had a set criteria that defines the cases at the very beginning, so outright. Now, in terms of the question we just wanted to focus on here was, do you think that there's a sufficient number of cases selected to be able to answer our question? Nope, Shola says no, and can you explain why? Basically, yes, perfect. I wanted to get to power as one of the things to talk about. So we don't know what the power is. Do you think that you can calculate it now yourself? Because we were thinking we could link you up to a sample size calculator that's available on the internet. Andrew, I think you've got have we got the link? That's it. So once you go onto this, yes, if you're interested, you can actually say, okay, well, you know the sample size that's been given by the study's results and outcomes, and you can work a little bit backwards and see what relative risk or odds ratio you require, what difference that sample size can actually detect, and you can sort of crunch the numbers and see how many. Hello, can you hear me? Sorry. No problem, no problem. Amazing. So the next question is number 4, were the controls selected in an acceptable way? So now we've decided that the case definition was okay, but we don't have enough numbers. So what about the controls? Do you think, yes, no, or can't tell, were they an acceptable way of picking up the controls, recruiting the controls? So Reaper says yes. Charlotte says can't tell. Cool. So they've yeah. Sure. So the way from what we understand from what they're saying is that the way they selected controls were going back to the same private practitioner who diagnosed the child with the empyema in the first place, and get that the other child who hasn't had empyema with an acute viral infection. So that's how they picked their control groups, which, as we were saying, is good in the sense that it's the same doctor that's diagnosing the acute viral infection, but there's a lot of other things that we could potentially think of matching to make these two groups more comparable, the cases and the controls. Is there anything else that do you know what they've matched for other than the fact that the same doctor diagnosed the acute viral infection? Did they do any other matching? Yes, and there was an age plus minus 1 year. And so age is important in this group, and I guess plus minus 1 year is okay for a 12-year-old, between a 13-year-old, but maybe more of a problem when it's between a 3-month-old and a 15-month-old. So that's something to think about. And then the other thing was about the control recruitment itself. Did you think that the control, when they recruited the controls, sorry, they said that they had trouble recruiting those controls? What sort of bias can be introduced by having trouble of recruiting these control groups? Yes. Exactly. And just going back to that rolling, yes, exactly. So going back to that rolling slice that we had in the middle, this could potentially introduce a non-response bias, which can then introduce a selection bias as well. So some people, yes, exactly. So this can potentially introduce selection bias. It can introduce non-response bias as well. And before we move on to the next question, I just wanted to go back to the matching process. Do you think any other variables should have matched to make these controls in the cases more comparable for this particular question to be asked? Yes. So we thought socioeconomic status could be one thing that we could also match for, making them more comparable. Because what they say in the demographics table is that they're similar in socioeconomic status when you look at the whole group, but actually they don't look at the people who have been matched one-on-one, what the socioeconomic differences were. And previous illnesses, they do exclude everyone who's had a previous diagnosed chronic respiratory tract infection, not infection, sorry, disease. But again, yes, having previous multiple respiratory tract infections, for example, could be relevant as well. Okay, so we think that actually the controls selected were acceptable, but there's lots of possibility that there might be some bias, and the numbers aren't great either. So we decided that we'd say no to can't tell for this one. So the next question in this section is, was the exposure accurately measured to minimize bias? Where our exposure is ibuprofen use, did you think that the definition of exposure was clear from the results? They do mention ibuprofen use in 1 to 3 consecutive days, so their definition is clear. But the way in which they actually identify how ibuprofen is selected is how ibuprofen use has been ascertained is quite interesting. The only thing is if they asked controls a long time. Yes, exactly. And Christine, what would that introduce? Because that is exactly what we were thinking as well. If they can't remember, it's a certain type of bias that it introduces. Yes, a recall bias. Thank you, Kate. And that we thought that actually the way in which they asked the question backwards introduced a high risk of recall bias. So again, there is a high risk of bias here. Now, going back to the prescription, what they did was they identified whether or not a person had ibuprofen through prescriptions, basically, whether or not the doctor had prescribed the ibuprofen. And that's an interesting way, because we don't know, was the child compliant with it? There were better ways that they could potentially have measured ibuprofen use. And yes, it did include previous adverse reactions to NSAIDs. So moving on to the next couple of questions.
It does say that they included self-administered medications as well. So I assume that would mean, yeah, according to the doctor's prescriptions and self-administered medications. So I think they are looking at over-the-counter.
Fine. Yes.
There's another thing that occurs to me, actually, just thinking about it now, which is not only the recall bias of potentially those who have the empyema, being more likely to recall use of ibuprofen, but actually my suspicion is you go to these GPs and you say, can you recruit someone who came with a viral infection in the last 14 days? I think they're much more likely to find someone who came a day ago or 2 days ago than they are to find someone 14 days ago, is my suspicion. Yeah. So I can just imagine that potentially those controls may have been questioned much sooner after, the onset of their viral illness than the children with empyema were questioned after the first onset of their illness. Anyway, just a thought.
No, absolutely. But either way, I guess the recall bias risk is quite high, given the time period that elapsed from the cases as well. And then the next question, I'm going to skip 6, I'm aware of time, 6A, and move straight on to 6B, which is, have the authors taken account of the potential confounding factors? Can you think of any other well, someone had alluded to it at the very beginning, but what confounding factor is particularly important that is going to cloud our analysis, do you think? I think it was, I just want to go to the very beginning.
It was Christine, I think, who brought it up.
I think it was Christine who wrote it up. Yes, it was Christine who wrote it up. Yes, exactly. Oh, you hadn't written out. Sorry, you had said it. That's right. So the severity of illness would have confounded our results in this situation as well. So we've got 2 minutes left, which is why we wanted to focus specifically on the internal validity part of this paper, because there's quite a lot to talk about. So actually, if I can stop there and ask you, do you think it's worth continuing to have a look at these results now that we have picked apart? Do we think the study is valid, basically, for us to have a useful interpretation of their results? I could try to do the drum roll. Single drum roll would be hard. Awesome, that's excellent. I think, as you said, the direction of it is being very suspicious about the results, but actually that we could potentially learn at least something from what the results are going to show us at this point, but to take it with a pinch of salt and to drive further studies to be able to actually understand whether or not there's a causation between ibuprofen use and getting empyemas. And that brings us to 2 o'clock. We can.
So I could briefly talk through show their key results.
Yes.
which we can continue to take with a pinch of salt and then see what people think. I mean, I think if we overrun by 2 minutes, it won't matter too much. So but basically, they present two main sets of results. There are some supplementary ones. The first one is looking at drug exposure within the first 72 hours of the initial infection. I don't know, you know, to me, it's not clear that everyone with an empyema would start with an acute viral infection, but we just have to accept that's what they said. And basically what they show is that any exposure to non-steroidal anti-inflammatories is higher among those who had the empyema than among those who went to the GP, who were the controls who went to the GP. And antibiotic exposure was less frequent, and both of those came out as significant. But those were what we would call crude estimates. They didn't take into account any other differences between the groups. What then confuses me is that, so this one, for the first 72 hours, they present these crude estimates. Then go to table 4. They then present what they say is the multivariable analysis. So this is where they've produced a more complex model where they're looking at the effects of antibiotics and non-steroidals and other things at the same time. With my quick read, I couldn't see exactly which other factors were included in that model. It might be in the supplementary material. But it perplexes me a little bit that they present a crude estimate for the first, for after 72 hours, sorry, was table 3, but then for within the first 72 hours, oh no, sorry, they're both within 72 hours. So effectively, these are the same results, but the same data, but analysed via 2 different means. And this one is the more nuanced one that tries to take into account the possible confounding. And you can see that the results remain significant, but I didn't quite grasp exactly which features were included in that model. So I guess as we come to wrap up, I'd be very interested to know, has this changed anyone's views on the safety of ibuprofen among children with presenting with an acute lower respiratory tract infection? Susie loves the NSAIDs. Okay, all right, fine. So I guess bottom line is this evidence alone, based on our short review, does not seem to have convinced people to move from their initial views, which some people expressed a degree of caution, but no one was totally resistant to the idea of ibuprofen. So there you go. We would love, as always, to have your feedback. I think this was a really tough paper to look at, so thank you very much for doing it so well. I pasted the survey link in there. Susie tells me we've got someone lined up for next week's theme, but it'd be great to have people lined up for the weeks after that. So please send us a message through this system or email me, andrew.mccardle@gmail.com. Should you have a clinical scenario question that you'd wish to work through. The beauty of this is you don't have to do all the hard work of appraising it because we do it together. So thank you so much. There are some useful resources, which I'm going to just paste in, just general sort of evidence-based medicine things there, which can be good. Thank you very much for your attention and perseverance. We'll draw this session to a close. Thank you.